Okay, now let's talk about the nursing care of patients with disorders of the urinary system. First condition we're going to talk about is cystitis, which is an inflammation of the urinary bladder. One of the most common urinary tract infections, especially in women, because the female urethra is shorter and the urinary meatus is exposed to contamination from the vagina and the anus. E. coli, which normally resides in the intestinal tract, accounts for 80% of all urinary tract infections in females. The signs and symptoms of cystitis are painful urination, frequent and urgent urination, and low back pain. The urinary meatus may appear swollen and inflamed. Cystitis has a tendency to recur with less acute symptoms like fatigue, anorexia, and constant feeling of bladder pressure occurring between flare-ups. In the elderly, they may present with symptoms such as confusion. If they are normally alert and become confused, you want to assess their urine for cloudiness, foul odor, or hematuria, and then check for other signs of infection. But oftentimes they'll present at first with confusion. Diagnosis of cystitis is based on the urinalysis and urine cultures. Treatment of cystitis is basically antibiotics. In postmenopausal women, they may be started on topical estrogen. We also encourage patients to take intake of at least 8 to 12 large glasses of fluid, unless of course contraindicated. Also encourage cranberry juice, which can help to alter the pH. I know they just had it on television again a couple days ago that there's no scientific proof stating that cranberry juice has an effect on frequency of urinary tract infections, but people do swear by it, so it doesn't hurt as long as they can. There's no other contraindications to drinking that, to encourage that as well. Sitz baths and hot water bottles can be offered for comfort, and we do teaching regarding preventing urinary tract infections. That would include always wiping from front to back after bowel movements and urination. Avoid wearing nylon pantyhose or tight slacks or any clothing that increases perineal moisture. Do not wash underclothing in strong detergents or bleaches. Change wet bathing suits or wet clothing as soon as possible. Showering may be preferable over bathing for women. Do not use bubble baths, perfumed soaps, over-the-counter vaginal douche products. Avoid prolonged bicycling, motorcycling, horseback riding, or traveling involving prolonged sitting, which can contribute to urethritis and cystitis. Empty the bladder promptly after sexual intercourse and drink 2 glasses of water to help flush out microorganisms from the urethra and the bladder. Vitamin C can help acidify the urine and decrease the frequency of cystitis as well. German chamomile is used topically for its anti-inflammatory and antibiotic properties to soothe the inflamed genital area. The next condition is urethritis, which is an inflammation of the urethra that can be caused by many different types of organisms. It's a common symptom of gonorrhea and should be investigated as soon as it is first noticed. Inflammation involving the urethra also can be caused by herpes virus. And then nonspecific urethritis is a sexually transmitted inflammation of the urethra caused by a variety of organisms other than gonococci, although it may be transmitted sexually. In women who experience trauma during childbirth and the proximity of the urethra to external genitalia in the anus predispose the urethra to infection and inflammation, and chemical irritation caused by the use of spermicide, jellies, bath powders, feminine hygiene sprays, and bubble bath can also cause urethritis. The signs and symptoms of urethritis are burning, itching, and frequency in voiding and painful urination. There may be discharge, which becomes increasingly purulent if gonorrhea is present. Diagnosis of urethritis is based on the presence of symptoms and a patient history that includes possible exposure to STIs. Culture and sensitivity of urine is obtained to identify the causative organism, and culture specimens are used to rule out STIs as well. The treatment and nursing management for urethritis is similar to cystitis. The nurse should be especially aware of the possibility of a gonorrheal infection and should carry out the necessary teaching to prevent spread of the infection to the eyes. The next condition is pyelonephritis. Acute pyelonephritis is an infection of the kidneys. It is thought to occur when bacteria such as E. coli from a bladder infection travels up the ureters to infect the kidneys. A common cause of pyelonephritis is an obstruction causing the stasis of the urine and stones that cause irritation of the tissue. When bacteria enter the renal pelvis, inflammation and infection can occur. After the infection is treated, the inflammation will subside. However, scar tissue is left in place of the healthy tissue previous to the infection. With chronic infection and inflammation, more scar tissue develops and eventually kidney function will become impaired. The signs and symptoms for acute pyelonephritis, symptoms include a fever, usually 103 degrees Fahrenheit or higher, then along with that chills, headache, malaise, nausea and vomiting, and pain in the flank, radiating to the thigh and the genitalia. Eventually the urine will be loaded with bacteria, blood, and pus. In the chronic phase, you may see weight loss, low-grade fever, weakness, and gradual scarring of the kidney tissues. Diagnosis is based on symptoms and physical assessment as well as the urine culture and sensitivity. Other tests such as the KUB or kidney, ureter, and bladder x-ray, the intravenous pyelogram, or even a renal CT may be obtained to determine the location of the obstruction if one is suspected. Treatment of cystitis and the prevention of recurrence can help to prevent acute pyelonephritis. After pyelonephritis has occurred, then bed rest, analgesics, and antipyretics are prescribed, and then the specific drug that is sensitive to the bacteria is chosen based on the culture sensitivity results. With chronic pyelonephritis, the patient may live for years without significant symptoms, and then they may develop renal damage, which leads to hypertension or kidney failure. Oops, sorry about that. Let's see here. So correction of the obstruction, removal of stones, and prevention of stone formation are essential to correcting chronic pyelonephritis to prevent any further destruction of the kidney cells. Acute glomerular nephritis is primarily seen in children and young adults and affects males more than females. It commonly occurs about 2 to 3 weeks after a group A beta hemolytic strep infection, such as strep throat or impetigo has occurred. It occurs in response to bacterial, viral, or parasitic infections elsewhere in the body. It is an immune problem caused by an antigen-antibody reaction. The antigen-antibody complexes are deposited in the glomerular basement membrane, causing cell damage and altered permeability. Renal tissue becomes scarred and function becomes impaired. The signs and symptoms: the patient in acute glomerulonephritis becomes suddenly ill with a fever, chills, flank pain, widespread edema, puffiness around the eyes, visual disturbances, and marked hypertension. The diagnosis is based on physical findings. Presence of hypertension is usually a late clinical manifestation. Diagnostic tests include urinalysis, creatinine, blood urea nitrogen, and complete blood cell count. The urine may be smoky. It will contain red blood cells and protein, and will have an increased specific gravity. Serum creatinine and BUN levels will rise above normal. If the condition is severe, the hematocrit and hemoglobin will be low and indicate anemia. Treatment for this illness could be a sodium-restricted diet if the patient has edema, and fluids may also be limited. A low-protein, high-carbohydrate diet may also be ordered. Plasmapheresis may be done. If the treatment is not successful, then the disease will rapidly progress to kidney failure and possible death. Okay. As far as nursing management goes, the nurse should obtain a history of past illnesses, especially infections or autoimmune disorders, for example, lupus. The nurse should then perform a general physical assessment, including vital signs and, of course, a baseline weight, and observe for any signs of fluid retention or edema. Mental status should be checked frequently for indications of cerebral edema. Cardiac failure or pulmonary edema also may develop because of the fluid volume excess. So you would observe then for extreme restlessness, increased shortness of breath or cyanosis, and be alert for changes in blood pressure, pulse, and respiratory rate. Decreasing the work of the kidney is the primary goal, so absolute bed rest is usually ordered until the clinical signs of hematuria, proteinuria, and hypertension are gone. If the patient responds quickly to treatment and wishes to be more active, you must emphasize the need for continued rest. A low-protein diet may be ordered if the BUN is elevated to help reduce the nitrogen waste byproducts. Low sodium or fluid-restricted diets may also be ordered if the patient is experiencing edema. Antihypertensives and diuretics are also ordered to control edema and high blood pressure. Plasmapheresis and corticosteroids can be used to reduce the antigen response in the inflammatory process. If the patient has plasmapheresis therapy, monitor the bleeding at the puncture site every 2 to 4 hours, and then also monitor for complications such as hypovolemia or electrolyte imbalance. The prognosis for acute glomerular nephritis depends upon the extent of the damage done to the kidneys and other vital organs. Chronic glomerular nephritis develops rapidly or progresses slowly over 20 to 30 years or longer. The exact cause is not known. Chronic glomerulonephritis, when it occurs, the kidney starts to atrophy, and there are a decreased number of functioning nephrons, and eventually the patient will experience kidney failure. The prognosis for the disease is poor. The progress of the renal failure varies with the individual. Signs and symptoms are generalized edema, headache associated with hypertension, fatigue, shortness of breath, weight loss, loss of strength, increasing irritability, and nocturia. Proteinuria, hematuria, and kidney failure occur as the kidney function becomes more and more impaired. Some patients who develop chronic glomerulonephritis may have acute exacerbations of the condition. Diagnosis is made by the findings of a routine physical exam. During that time, they may discover retinal hemorrhaging during an eye exam. Maybe a urinalysis will come back positive. Creatinine, BUN, CBC, and electrolytes also may indicate the disease. Abnormal laboratory values include proteinuria, urinary casts, elevated creatinine and BUN levels, anemia, hyperkalemia, hypermagnesemia, and increased phosphorus and decreased serum calcium and albumin. Treatment is primarily symptomatic, with emphasis on avoiding fatigue and infections, especially upper respiratory infections. When renal failure develops, then dialysis and possibly a kidney transplant are really the only alternative therapies. Okay, renal stones are crystal masses that form in the urinary system, and depending on the size and the location, may obstruct the flow of urine. Stones can be as small as a grain of sand or large enough to fill the whole renal pelvis. The enlarged stone formations are called renal staghorn calculus. Renal stones, of course, vary in composition and in the environment which they form. Some stones form more from a more acidic urine, where others form from a more alkalinic urine. There are 4 major types of renal stones, and if you look on page 794, table 34.2 presents the risk factors and treatment for renal stones, and within that table you'll see the different stone types. There's calcium oxalate, which is the most common type of renal stone, a calcium phosphate, uric acid, struvite, and cysteine. And then the risk factors and the interventions are listed beside those. So the calcium oxalate, which is most common type, the risk factor is an increased intake of protein, sodium, inadequate fluid intake, and prolonged immobility. The interventions would be then to increase fluid intake, to take medications to bind oxalate or calcium, take diuretics to encourage flushing, and avoid oxalate sources such as spinach, chard, parsley, peanuts, chocolate, and strawberries. For calcium phosphate, the risk factors are increased intake of protein, sodium, inadequate fluid intake, and primary hyperparathyroidism. The interventions would limit intake of food high in protein and sodium, and to treat the underlying hyperparathyroidism. For uric acid stones, the risk factors are excessive dietary purine and gout, and the intervention would be then to decrease intake of purine sources, alkalinize urine with potassium citrate or lemonade, and then administer allopurinol for gout. For a struvite stone, which is more common in women, the risk factor is urinary tract infections, and the intervention would be to administer antibiotics for infection and acetohydroxamic acid, which would inhibit the chemical action of bacteria that contributes to the struvite stone formation, to take as prescribed. The cystine stone, the risk factor is hereditary cystine crystal formation. To intervene, we would encourage oral fluids up to 3 liters per day, if not contraindicated, and medications to prevent crystallization, and alkalinize the urine with potassium citrate or lemonade. Causative factors of the renal stones would be the supersaturation of urine with crystalloids that do not readily dissolve, such as calcium, uric acid, and cystine, urinary infections which can produce bacteria and other debris that form a core for the stone formation, inadequate fluid intake which results in concentrated urine and inadequate flushing of the urinary tract, sluggish flow of urine as may occur with bed rest or immobility, and certain substances in the urine, such as uric acid, which encourage the formation of crystals of calcium oxalate or calcium phosphate. Here's a picture of a renal staghorn calculus, and you can see how the stone pretty much takes the shape of the renal pelvis. Prevention of stones is a continuous flow of dilute urine would flush the urinary tract and remove substances that could form stones. Again, ideally, adults should put out at least 3,500 milliliters of urine every 24 hours to prevent stone formation. Likewise, preventing urinary tract infections and maintaining adequate drainage through tubes and catheters is also necessary. In cases where the urine pH is causing the stone formation, changing the urinary pH can prevent or reduce the incidence of renal calculi. So ascorbic acid or dietary modifications, such as cranberry juice, prunes, or lemon juice, can be used to acidify urine. The signs and symptoms of renal stones are as follows. Depending upon the location of the stone, some persons may not have any symptoms while others may have severe symptoms. Kidney stones that cause severe pain are those that are small enough to move along the ureter with the urine. As the stone rolls along, sharp little spikes scrape the ureteral lining, causing severe pain and bleeding. Pain is typically felt in the flank over the affected kidney. The pain radiates downward toward the genitalia and inner thigh. Nausea and vomiting often occur along with the severe pain. Moving stones can get trapped along the ureters and cause obstruction of flow and swelling of the ureter. Diagnosis is made based on a urinalysis, which shows blood in the urine, and also a kidney ureter bladder study to locate stones, which will show up as a radiopaque material on the KUB. An IVP can also be performed. As far as other blood and urine studies, Levels of substances such as calcium, uric acid, and cysteine can also identify reasons why stones are forming. So treatment, at first, provider tries to flush the stone out by increasing the patient's oral intake or their IV fluids, and by managing their pain by prescribing maybe an opioid analgesic or a nonsteroidal anti-inflammatory drug. If there's pus in the urine, then an antibiotic is also prescribed. Some stones can be flushed by irrigation through a ureteral catheter or percutaneous nephrostomy tube, or crushed by ultrasound. Usually a stent is placed in the ureter to allow the stone fragments to pass freely. Extracorporeal shock wave lithotripsy has largely replaced surgery for renal stones. Oops. I just want to take a moment just to let you take a look at where a nephrostomy catheter is placed. It's placed into the renal pelvis. The catheter is very tiny. It comes out and it drains into a drainage bag so that the urine doesn't sit in the renal pelvis, because the obstruction of the ureters won't let the urine flow freely down into the bladder. So they put a nephrostomy catheter in to drain the urine out through the patient's back and into this little this little drainage bag. So if the doctor has an order to irrigate that nephrostomy tube to keep it patent, you never use more than 5 cc's to irrigate it, because you're pushing that fluid into the renal pelvis, and it's such a tiny area, you're certainly not going to want to irrigate it with much fluid. When you're collecting your urine outputs, you separate on your INO the amount of urine that drains out of your nephrostomy catheter into your drainage bag, and separate that from the amount of urine that maybe is either draining into your Foley catheter drainage system or the patient is voiding. So you keep those amounts separate. Let's see, so we left off with the extracorporeal shock wave lithotripsy, or ESWL. For this treatment, the patient is placed in a water bath, and shock waves are generated, pass through the water, bounce off a reflector, and break the stone. Sedation is used to help the patient remain calm during the 30 to 45 minute procedure. Or in some cases, the patient may be given a general anesthetic. After the procedure, the patient may experience cramping pain, so is given pain medications. And if possible, a fluid intake of 3,000 to 4,000 milliliters is necessary to help wash the stone fragments from the kidney. A tube could be placed in the kidney either through the bladder or through the back that will drain the fluid and stones from the body. And we just looked at that in the previous slide. Adjunct therapy for ESWL includes corticosteroids and calcium channel blockers. Percussion, diuresis, and inversion therapy can be used after ESWL, and in this procedure diuresis is promoted and the patient is placed prone in a reverse Trendelenburg position and massaged or percussed to encourage stone movement. If the stone is not passed spontaneously, then cystoscopy or other surgical intervention may be necessary. A nephrolithotomy, where there's an incision into the kidney to remove the stone, may be performed, or a pyelonephrolithotomy, surgical removal of a stone from the renal pelvis, can be performed for large stones that will not pass. These procedures can be done percutaneously, or rarely on occasion they could be an open procedure. Nursing management with the patient with a kidney stone. Patient has extreme pain, so we assess the pain and then attempt to relieve the pain. Also, we want to have the patient pass the stone, as if possible spontaneously, and then we need to strain the urine to recover any stones or fragments so we can send them to lab for analysis. So fluids are encouraged to flush out the stone. In some cases, when the patient's discharged, we even send strainers home with the patient so he can strain his urine at home, with the instructions that if he retrieves any stones, he brings them to the lab for evaluation. Okay, let's take a look at the common catheters and tubes that are used for urologic disorders. The first one is the urethral catheter, which drains the urine from the bladder. The Foley catheter is an indwelling catheter for continuous urine drainage from the bladder. Suprapubic catheter is a continuous drainage of urine from the bladder. The suprapubic catheter is inserted in the suprapubic area of the abdomen through the abdominal and bladder wall. The ureteral catheter drains urine directly from the ureter or the kidney. The ureteral stent is a tube that's inserted in the ureter to hold it open while it heals. It's not visible on the outside of the body, it's inside the ureter. And then the nephrostomy tube is the tube that's placed in the pelvis of the kidney to provide drainage of urine directly from the kidney. Okay, let's take a look at bladder cancer. Bladder cancer is more common in men, ages 60 to 80 years, than in women. Smokers have double the risk of developing the cancer. People living in urban areas or with occupational exposure to nitrates, dyes, rubbers, and leather processing are also at higher risk. The bladder wall is exposed to these carcinogen chemicals in the urine, and tumors of the bladder usually start in the superficial transitional cell layer, and they're considered to be papillomas. Bladder tumors are removed even though they are papillomas because they have a high risk for invasion into the deeper tissues. The main symptom of a bladder tumor is blood in the urine. Frequency, urgency, or dysuria may also be present. Diagnosis is confirmed based on an IVP or by actually examining the bladder wall during a cystoscopy. Bladder tumor can also be biopsied while a cystoscopy is performed. Smoking cessation and a diet including vegetables such as cabbage or broccoli contribute to a healthy bladder and decrease the risk of bladder cancer. Treatment for bladder cancer may be surgery, either alone or in combination with chemotherapy or radiation. Bladder surgery can be minor, such as removing polyps from the bladder using a cystoscope, or it can be major, such as a cystectomy, which actually removes the bladder for bladder cancer. After cystectomy, hemorrhage and infection are always a danger. When the bladder is surgically removed, the surgeon performs a urinary diversion to handle the excretion of urine, and she creates an artificial opening or stoma on the skin surface. Diversions are also performed for neurogenic bladder, congenital anomalies, strictures, or trauma. And there are several ways in which urinary diversion can be accomplished. urinary diversion can be accomplished, including ileal conduit or an ileal loop, a cutaneous ureterostomy, a vesicostomy, a ureterosigmoidostomy, or a sigmoid conduit and ileal reservoir. It all differs depending upon the segment of the bowel that is used. So a cutaneous ureterostomy or vesicotomy is where a surgical incision into the ureter is made that diverts the flow of urine. In a cutaneous ureterostomy, the surgeon detaches one or both of the ureters from the bladder and brings them to the surface of the body, usually in the region of the flank. The patient may have one or they may have two stomas, as you can see in the picture. If the patient has a cutaneous ureterostomy with two stomas, the flow of urine from each stoma must be measured. Any tubing leading from the ureterostomy should be kept open so the urine can flow freely. The tube is checked frequently for signs of obstruction by mucus or blood clots. Conduits collect urine in a portion of the intestines, which is then opened onto the skin surface as a stoma. After the creation of a conduit, the client must wear a pouch. So an ileal conduit is also called a urinary ileostomy. A portion of the ileum is used as a tube or a conduit through which urine flows to the outside. The section of the ileum is separated from the intestinal tract. Urine does not flow through the intestines, as when the ureters are sutured to the sigmoid. The two open ends of the intestines, where the section of the ileum was removed, are rejoined then by anastomosis. The borrowed section of ileum is sutured together at one end to form a pouch, and the other end is brought outside to form a stoma. The ureters are attached to the ileal conduit so the urine can flow through the conduit to the outside. An ileal reservoir diverts urine into a surgically created pouch or pocket that functions as a bladder. The stoma is continent, and the client removes urine regularly by self-catheterization. The picture that you see on the screen now is an example of a continent internal ileal reservoir called a cock pouch. The nursing management postoperatively is for after the surgery is to observe for pain, assess for abdominal rigidity, fever, and signs of bleeding. You need to assess the amount and characteristic of the urine and mucus and record accurate output of urine every hour for the first 24 hours and then every 4 to 8 hours. Regardless of which surgical procedure the patient has had, the urine should never stop flowing. The urine may be light red or pink and progress to clear within 3 days or less. Bright red bleeding or clots should be reported immediately, as this could be a sign of bleeding. The stoma should be pink or red. A pale, dark, or dusky stoma suggests decreased blood flow, again which should be reported immediately. Skin irritation and breakdown can be a problem, so every effort should be made to keep the urine from touching the skin when the patient has an external stoma. Need to make sure that the appliance is well fitted and properly adhering to the skin. Most appliances contain an odor barrier. However, odor may still be a problem because of poor hygiene and alkaline urine. Dilute urine is also less odorous and can be accomplished by increasing the fluid intake. Reusable appliances should be washed with soap and water and soaked in a dilute white vinegar solution, or a commercial deodorizing product for 20 to 30 minutes. The pouch is then rinsed and allowed to dry. Deodorant tablets may be placed in the appliance to decrease the odor as well. Psychological care of a patient who's facing malignancy in an operation will radically change his body image. So that should be a primary concern for the nurse. Also, there's always the sexual concerns when a urinary diversion is performed. Encourage the patient and significant other to talk about fears and concerns and provide emotional support, and then help the patient and family identify appropriate community resources and make referrals as necessary. Acute renal failure occurs suddenly as a result of physical injury, infection, inflammation, or damage from toxic chemicals. Nephrotoxic agents are those that are poisonous to the kidney cells, and these include drugs, heavy metals, and exposure to industrial chemicals. These toxins inflict damage on the renal tubules, causing acute tubular necrosis and loss of function. They can also indirectly harm the tubules by causing severe constriction of the blood vessels. These blood vessels serve the kidney, once constricted, can produce renal ischemia. Other causes of renal ischemia are circulatory collapse, severe dehydration, and prolonged hypotension. Pre-renal acute renal failure is caused by a decreased blood flow, such as in hypovolemic shock, or decreased cardiac output, such as in cardiogenic shock. Intrarenal, ARF, occurs when glomerular damage occurs. ATN, caused by ischemia or toxins or vascular disease that affects the vessels in the kidneys. Postrenal ARF is caused by obstruction in the ureters, bladder, or urethra. So, for example, an enlarged prostate causes eventual backup of urine into the kidneys, which in turn leads to tissue damage. Acute renal failure is potentially reversible, especially if identified early, and patients can often regain their kidney function. Here you see the concept map, the pathophysiology of renal failure. So in acute renal failure, if you look at the top, there's the next row is the pre-renal, intrarenal, and post-renal steps in the concept map. If we have pre-renal, it will cause decreased blood flow and decreased oxygen, which will result in tissue damage, decreased glomerular filtration rate, decreased tubular function, decreased hormone secretion, and then decreased ability to excrete fluids, hydrogen, potassium, sodium, nitrogenous waste, and phosphorus, and decreased erythropoietin secretion, and decreased vitamin D, and decreased serum calcium. If you look at intrarenal, such as nephritis, nephrotoxins, acute glomerular nephritis, etc., that will cause tissue damage and then result in decreased glomerular filtration rate, decreased tubular function, decreased hormone secretion, and then down to the bottom again, decreased ability to secrete fluids, electrolytes, minerals, and decreased erythropoietin, etc. Then if you look at postrenal, third box on top, it will result in obstruction and backup of urine with increased pressure, which causes tissue damage, decreased glomerular filtration rate, decreased tubular function, etc. Looking at chronic renal failure, it can result in tissue damage, decreased glomerular filtration rate, decreased tubular function, etc., or it can result in fluid overload, metabolic acidosis, hyperkalemia, sodium imbalance, azotemia, anemia, and osteodystrophy. Then looking at the renal insufficiency, a diminished renal reserve, and end-of-stage renal disease will result then in fluid overload, metabolic acidosis, hyperkalemia, sodium imbalances, azotemia, anemia, and osteodystrophy. So it's just a concept map comparing acute renal failure with chronic renal failure and renal insufficiency. What are some of the signs and symptoms of renal failure? Actually, renal failure has an effect on the entire body. We look at changes in urine output and urine results, such as specific gravity and proteinuria. Electrolyte imbalances can occur, hyponatremia, hyperkalemia, and hypocalcemia. Fluid imbalance, hypotension, hypertension, edema, and pulmonary edema. An acid-base imbalance, metabolic acidosis. GI effects such as nausea, vomiting, anorexia, and constipation. Mental status changes such as lethargy or memory impairment. Anemia and platelet dysfunctions to result in fatigue. You may see signs of bleeding and bruising, and impaired wound healing and susceptibility to infection. Diagnosis is made based on urinalysis, creatinine, BUN, CBC, electrolytes, and arterial blood gases. In addition, radiologic studies such as ultrasound, IVP, CT, and MRI can be performed, especially if an obstruction is suspected. A renal biopsy can be obtained to assist in determining the cause and evaluate the extent of the kidney damage. Treatment of acute renal failure is aimed at correcting the underlying cause and preventing complications and maintaining a tolerable internal environment until the kidneys are able to recover. Symptomatic treatment includes correction of fluid and electrolyte balances, management of anemia and hypertension, and cleansing the blood and tissues or waste products with hemodialysis, which is the filtration of blood across the semi-permeable membrane, or peritoneal dialysis, which is filtration of blood across the peritoneal membrane. Fluid overload is treated with diuretics and sometimes low-dose dopamine to promote better kidney perfusion. Dialysis is used to reduce volume overload if it cannot be reduced with drugs. Electrolyte imbalances are monitored and treated. Metabolic acidosis, if severe, is treated with IV sodium bicarbonate. Dialysis with a buffer solution may also be used. Other problems that can occur: malnutrition, anemia, and potential for infection. Patients may be started on total parenteral nutrition. Potassium, phosphate, and magnesium are omitted from the solution, especially when the patient is not putting out much urine. Anemia occurs because the kidney cannot produce normal amounts of erythropoietin, and the lifespan of the red blood cell is shorter because of the toxic waste in the circulation, and also the hemodilution from fluid overload. Providers may order Epoetin alpha or Epogen, a synthetic colony-stimulating medication. Infection is common in ARF and actually is the leading cause of death, so nurses must be vigilant to monitor for signs and symptoms of infection. So as far as nursing management goes, nurses must assess for signs of fluid imbalance. They must assess urine output and report if urine is less than 30 milliliters an hour. We need to monitor electrolytes, especially sodium and potassium. We must do a nutritional assessment and report if patients aren't able to take adequate nutrition. They may need to be started on TPN. We encourage optimal ADLs, so as much as possible the patient should be encouraged to participate in his care. And we also encourage good hand hygiene to prevent infections. Okay, during the oliguric and non-oliguric phase, the patient puts out either a great deal of or very little urine. Oliguria is a urine output of 100 to 400 milliliters in 24 hours. This phase usually occurs immediately or within 1 week after an ischemic event and lasts for an average of 10 to 14 days. However, it can go on for weeks to months, and prolonged oliguria worsens the prognosis. BUN and creatinine levels rise. When this occurs, there may be volume overload, which can precipitate in heart failure. Multiple electrolyte imbalances, metabolic acidosis, catabolism, which is the breakdown of body tissues, and actually end-stage renal failure. At this point, the dialysis is necessary. Because of the overall decreased kidney function related to aging, the elderly patient may be experiencing oliguria even though urine volumes are as high as 600 to 700 mils per day. Non-oliguric acute tubular necrosis is often due to nephrotoxic agents. Urine output is greater, but the kidneys cannot eliminate waste products efficiently, and the BUN and creatinine levels rise and electrolyte imbalances occur. Dialysis is needed less often or for shorter periods of time, and the prognosis is better than for the oliguric failure. The diuretic phase only occurs if dialysis has not been started early and extracellular fluid volume has built up. In this phase, the kidney is unable to concentrate urine, and output can be between 1,000 and 2,000 milliliters per day. With this increased output, there is a danger of dehydration, hyponatremia, and hypokalemia. Approximately 25% of the deaths that are related to ARF occur during this phase. During the recovery phase, kidney function begins to normalize. The concentration of urine output, and electrolyte balance begin to recover. There are 1 to 2 weeks of rapid improvement and then a period of slower recovery lasting between 3 to 12 months. About 1/3 of ARF patients are left with residual renal insufficiency, and about 5% must continue on dialysis. For chronic renal failure, the disease is a progressive loss of kidney function that develops over the course of many months or years. CRF is caused by destruction of nephrons. All the factors that cause ARF can also cause CRF. Hypertension, diabetes mellitus, sickle cell disease, glomerular nephritis, nephrotic syndrome, lupus erythematosus, heart failure, and liver cirrhosis may also contribute to chronic renal failure. The primary cause of nephrosclerosis are hypertension and atherosclerosis disease of the small arteries in the kidneys. Diabetic nephropathy or kidney disease and dysfunction secondary to diabetes mellitus, is the most common cause of death in patients with diabetes mellitus. So Healthy People 2020 has the goal to reduce kidney failure due to diabetes. Help your patient understand the relationship between diabetes and kidney health. Nephrosclerosis is classified as either benign or malignant, depending on the severity of the disease and the speed with which hypertension and atherosclerosis changes occur. The symptoms of nephrosclerosis are similar to those of chronic glomerular nephritis and renal failure, and the treatment is to control hypertension. In the early stages of chronic renal failure, renal function can be adequate, but the waste products begin to accumulate in the plasma. The patient will not experience symptoms until about 65% of the kidney tissue is damaged. As the disease progresses, nitrogen waste products such as urea nitrogen and creatinine tend to build up in higher levels in the blood. And in the final stage of renal failure, almost 90% or more of the kidney function is lost. Azotemia is the accumulation of nitrogen products, which is signaled by an increase in the BUN and serum creatinine. The kidney is not able to excrete potassium, therefore be alert for high levels of serum potassium, which can adversely affect the heart, causing dysrhythmias and cardiac arrest. The patient may also experience nausea and vomiting and changes in their mental awareness. There are 3 stages of chronic renal failure. Stage 1 is a diminished renal reserve, but no accumulation of metabolic waste. The kidney just works harder. Urine concentration is decreased and polyuria and nocturia occur. In stage 2, this stage is signaled by a rise in circulating metabolic waste, so you'll see an increase in the BUN and serum creatinine. Glomerular filtration rate begins to fall, and oliguria and edema occur. In stage 3, circulating metabolic wastes accumulate in the blood, and homeostasis cannot be maintained. Electrolyte and fluid imbalances become serious, and dialysis or kidney transplant is necessary to maintain life. Here you see a picture that is in your textbook on page 805. It's figure 34-3, and it's the systemic effects of uremia, or elevated urea in the bloodstream. So you will see psychological effects such as anxiety and depression, cardiovascular effects of hypertension, heart failure, coronary artery disease, pericarditis, and peripheral arterial disease, GI effects of anorexia, nausea, vomiting, gastrointestinal bleeding, and gastritis. You may see endocrine and reproductive effects of hyperparathyroidism, thyroid abnormalities, amenorrhea, erectile dysfunction. Metabolic disorders such as carbohydrate intolerance and hyperlipidemia, hematological disorders, anemia, bleeding, and infection, neurological changes such as fatigue, headache, sleep disturbances, and encephalopathy, ocular such as hypertensive retinopathy, pulmonary edema, uremic pleuritis or pneumonia. Integumentary, there may be pruritus, ecchymosis, and dry scaly skin. Musculoskeletal is vascular and soft tissue calcifications, osteomalacia, and ostitis fibrosa. and then peripheral neuropathy, such as paresthesias and restless leg syndrome. Signs and symptoms of chronic renal failure, again, do not appear early in the disease. Maybe a high normal elevation of BUN is an early warning sign, but the patient is likely to be asymptomatic. One of the earliest signs of renal impairment is the inability of the kidneys to concentrate urine. This produces polyuria and very dilute urine, and the patient may report nocturia. Renal insufficiency can produce occasional headaches and fatigue, but these symptoms usually go unnoticed. At this point, the kidney function is about 20 to 40% normal. As renal insufficiency progresses, the kidneys may not be able to produce much urine at all, and this results in oliguria and eventually anuria. The uremia or uremic syndrome includes clinical signs and symptoms that affect the entire body during ESRD. We kind of talked about that when we looked at that picture in the previous slide. Uremia signs generally appear when the BUN concentration passes 100. So the dialysis is usually initiated, and the goal is to maintain the BUN below 100 and to keep the creatinine below 8. Skin will become dry and scaly and be kind of a yellowish gray. Severe itching will occur. You may see uremic frost appear as evaporated sweat leaves urea crystals on the eyebrows, face, axilla, and groin. Calcium is not absorbed from the intestinal tract, and this leads to loss of calcium from the body and a corresponding drop in serum calcium. Patient will eventually suffer from muscle cramps, twitching, and possibly seizures. An elevated serum phosphate level serves to exaggerate the problem of inadequate calcium absorption, and phosphate binds with calcium, decreasing its absorption from the intestinal tract. Patient is hypertensive from fluid overload and body weight increases. Pulmonary edema and heart failure may occur. Triglycerides become elevated, and patient develops carbohydrate intolerance. The dietary protein is restricted in an attempt to decrease the waste products that the kidney can't handle any longer, so serum protein is decreased. Anemia is present because of the decreased production of erythropoietin. Patients suffer from anorexia, nausea, and vomiting because of GI mucosa irritation from waste products circulating in the blood. Constipation from drug therapy and fluid restriction is common. Patients may complain about restless leg syndrome, or leg discomfort may interfere with sleep. When the circulating wastes are increased, the nervous system cells become irritated, and the patient becomes irritable and short-tempered. As far as diagnosis, since creatinine is a stable byproduct of skeletal muscle activity, it's excreted completely by the kidneys, so creatinine clearance is a good measure of glomerular filtration rate. Creatinine clearance depends on the amount of blood passing through the kidneys, so narrowing of the renal arterioles or dehydration decreases the volume that is available to the kidney for filtration. Creatinine clearance is also affected by the functional abilities of the glomeruli. Urine collected for a 24-hour period and urinalysis with culture and sensitivity, hematocrit, and hemoglobin will provide additional information regarding the renal status. a renal ultrasound, a renal scan, CT scan, or a renal biopsy are additional diagnostic tests. Treatment of chronic renal failure includes measures to correct fluid and electrolyte imbalances and acid-base imbalance. Decreasing protein in the diet may help slow the disease process. A variety of drugs such as antacids, antihypertensives, antilipemics, epoetin alpha therapy, and vitamin and mineral supplements are used to counteract the fluid and electrolyte imbalances, treat metabolic acidosis, and control complications. If you look at table 34-4 on page 806, it'll give you a listing of the common drugs that are used to treat chronic renal failure. So we look at diuretics that are used while there's some remaining kidney function to help eliminate excess fluid. Inotropic agents such as digitalis are used in severe cases of heart failure. Anti-seizure meds may be needed because of uremic toxins causing an irritation of the nervous system. Dialysis and kidney transplant are two major alternatives offering hope for the patients with end-stage renal disease. Renal dialysis is indicated for acute renal failure or for renal insufficiency when the disease does not respond to diet, medications, or fluid restrictions. It's also used for patients with end-stage renal disease, drug overdose, hyperkalemia, fluid overload, and metabolic acidosis. Hemodialysis and peritoneal dialysis rely on diffusion to remove waste elements that are normally excreted in the urine. The principle of diffusion states that solute molecules that are in constant motion tend to pass through a semi-permeable membrane from the side of higher concentration to the side of lower concentration. So in hemodialysis, the blood moves from the arterial circulation through a dialysate bath and then back to the venous circulation. So hemodialysis is using a machine to filter out the toxins and then replace the blood back into circulation. The molecules of waste pass through the membrane out of the blood and into the dialyzing solution until the two solutions equal in concentration. Initially, there may be a temporary access for hemodialysis that's inserted into a jugular or femoral vein to access the blood supply. Only trained dialysis staff should be accessing these sites for medication administration or blood draws. There are two kinds of internal access used for ongoing hemodialysis. One is an arteriovenous fistula, or AVF, which is formed by joining an artery and a vein together. The vein is made into a large superficial vein with an arterial supply that is easily accessible by venipuncture. Typically, we find an AV fistula in the radial or brachial artery, which is joined to the cephalic vein in the arm. After 6 to 8 weeks after surgery for putting this AV fistula in, the vessel walls become thick enough and usable enough for repeated insertion of a hemodialysis needle. Although the AV fistula has fewer complications, it requires relatively healthy blood vessels, so patients with diabetes or prolonged IV drug use are not good candidates. The arteriovenous access, or AV, is accomplished by connecting an artery and a vein with a graft of a piece of synthetic material. The the hemodialysis needles are then placed directly into that graft. Medications commonly prescribed for patients undergoing dialysis include multivitamins, antacids, iron and calcium supplements, antihypertensives, epoetin alpha, phosphate binders, and possibly anticonvulsants. Complications of hemodialysis. Our patients can experience fluid overload, electrolyte imbalance, alteration in blood components, leading to anemia and platelet abnormalities that produce bleeding tendencies. Hepatitis C and acquired immunodeficiency syndrome are dangers because of blood access and the risk of contamination. So patients who had multiple blood transfusions during the early to mid-1980s may have been exposed to HIV. And hepatitis B is also possible, but is less of a concern because of the vaccination and antibody testing that occurs, as well as strict body fluid precautions. Nursing management of dialysis patients. First of all, once the graft or the fistula has been placed, it's important to check the site and protect it from injury. The site should be observed at least 4 times a day for signs indicating clotting or infection. And the peripheral circulation distal to the graft should also be checked. Checking capillary refill time or color of nail beds. Palpate for the thrill, which is a vibration in the vessel, by gently laying your fingers on the enlarged vessel. You should be able to feel a buzz or a vibration. A bruit should be clearly heard on auscultation, and the rhythm of the sound should coincide with the patient's pulse. When the graft has been inserted, the extremity should be elevated post-operatively and kept above the level of the heart for 24 to 72 hours. Care should be taken to never compress the extremity containing the vascular access, so no blood pressures, etc. Other bits of important information for caring for a renal dialysis patient. Antihypertensive drugs are not given the morning of dialysis because they can cause severe hypotension during the treatment. Nitroglycerin patches, digitalis, and anticoagulants should also be held. Consult with the dialysis nurse to coordinate the timing of the medications. Before the patient goes to dialysis, do your assessment, check for the brewery and the thrill at the access site, and get a complete set of vital signs and a weight. We need those measurements so we can compare them with the post-treatment results. Plan to assess the patient more frequently in the hours after dialysis treatment is completed, because the patient is going to undergo considerable fluid shifts that affect homeostasis. Post-dialysis nursing care should include monitoring the access site for bleeding for at least an hour after the treatment, and assess the patient for signs of confusion, disorientation, hypotension, nausea, vomiting, headache, dizziness, or muscle cramps. Invasive procedures are postponed for 4 to 6 hours after dialysis because the clotting time is extended from heparin used during dialysis, and prolonged bleeding can occur. Peritoneal dialysis differs from hemodialysis, in that during peritoneal dialysis, dialyzing fluid that is equal in osmolality and similar in composition to normal body fluid is introduced into the peritoneal cavity via a Tenkhoff catheter by gravity or by pump. Medications such as heparin, insulin, potassium, or antibiotics may be added to the solution. The solution is left in the peritoneal cavity for a specified time until the concentration of the solution on either side of the peritoneal membrane is equalized. Then after the fluid is infused, the patient can move about during that dwell time while the dialyzing solution is in their peritoneal cavity. At the end of the dwell time, the dialysate solution containing waste products is drained from the abdominal cavity, and the drainage should be colorless or straw colored unless the catheter was recently inserted. Then there may be a little bloody drainage for the first several treatments.